rounded, for if you insert without it slightly prowled, you run the risk of having the sharp edge on the harvester cutting the articular cartilage. When inserting the donor harvester, the portal should be enlarged so that it slides in easily. If one forces it in, the sharp edge can cut the articular cartilage. With this knee, the sulcus terminalis again is well delineated. One then comes 90 degrees to just above that for harvesting of the plug. There are 4 different quadrants marked, and one should maintain these as orientation for any obliquity that can occur with that of harvesting of the plug, and also the advantage of maintaining the orientation of the articular cartilage to match that of the recipient site. By removing the soft tissue, you can see that you can get over top of the core, so you have 1 millimeter outer wall remaining. If there's any question as to the proper orientation, one can gently insert to the point at which they deem is appropriate, and then remove to see the outline of the plug to be harvested. On initial insertion, you can make certain that the height is equal in all 4 quadrants. At this point, one can still make minor adjustments by angling. However, if one waits until it's inserted 5 millimeters or greater, any change in angulation can result in breaking of the plug to a much shorter length than desired. It's also very important that once the orientation is determined, one does not alter it once it is embedded in the bone, otherwise they run the risk of breaking the plug. As you can see, as the harvester advances, there are 5 millimeter increments to show you the depth of the plug. Typically, one makes a 15 millimeter donor plug. Okay. Once the harvester is inserted to 15 millimeters, it is turned briskly 90 degrees to the right and then to the left, and with this the plug is removed. In this situation, you can see that it's 15 millimeters around in proper orientation with a millimeter of lateral wall remaining. As you can see with the donor harvester, we have it flush to the end of the bone. In this case, you do not have to worry about making a difference in the depth. If by some chance it is broken oblique, then you need to push the graft out until the edge is flush, and then you read the depth, at which point that is what you should match the recipient site. You can take a look at all 4 quadrants to see if the plug has any areas of being prowled in relationship to the other 3 quadrants, and this is useful in trying to match the donor site if there is any alteration between the 2 sites. In this situation, we have 15 millimeter depth in all 4 of the quadrants. When preparing the recipient plug, the same principles should be used as that of the donor plug. One should make the portal large enough so that the recipient harvester slides easily into the joint, and also to make sure there's no soft tissue entrapped, which can make visualization difficult. With the recipient harvester, one comes directly over that of the defect with the goal of being 90 degrees perpendicular to that of the articular cartilage. If there's any question as to the appropriate size of the harvester, one can gently mark it and then remove it, and you can see in this situation the 6 millimeter harvester is the appropriate size. Once again, one needs to make certain that the 4 quadrants are equal and symmetric. Just as with the donor plug, it behooves you to be able to see all 4 quadrants and to make certain there's a few millimeters of the soft tissue away from the end of the plug. Remember, once it is engaged, only make minor adjustments and not large ones, otherwise the bone can be broken free as it is harvested. The recipient harvester is advanced just beyond that of the 10 millimeter line, stopping 2 to 3 millimeters short of the donor plug. This prevents the subsidence of the plug and also enables a true press fit of the plug at its base. When removing the recipient plug, one has to be careful not to toggle, as this can cause the plug to be broken in a shorter length and also can enlarge the opening so it would not be a true press fit fashion. To confirm proper depth and orientation, an alignment stick is then used. Commonly the depth is 15 millimeters. However, the exact depth should be determined by the length of the donor plug. The donor harvester is then obtained and the screw-in device is inserted. By using this method, it gradually pushes the plug out of the end and is less traumatic than if one tamps it or hits it firm with a mallet. As you can see, just in this circumstance, when I'm turning it, you can see that it protrudes out the end of the harvester. The clear delivery tube is of great benefit. It helps keep all the soft tissue away so the visualization is readily achieved, and it also prevents the graft from being inserted too deeply within the tunnel. The clear delivery tube is then placed over the defect and the donor plug then inserted by advancing the core extruder. If there's any difficulties or concerns of the pressure making it difficult to advance the core, the inflow can be stopped at this point. In addition, there's a tendency for the clear cannula to be pushed backwards as the core is inserted, and thus firm pressure needs to be applied as the plug goes in. With the delivery system inserted fully, it leaves the plug approximately 1 millimeter prowled. The tamp is 1 millimeter greater in diameter than the plug itself to prevent overcompression and insertion of the plug. By using the tamp to insert the last millimeter, you can see that the plug can fit flush with that of the surrounding articular cartilage. In addition, with a press-fit fashion, one can see that the concerns of early range of motion or accelerated rehab are less than if plugs are not in press-fit fashion or when using fibrocartilage techniques. As with any surgical procedure, in particular arthroscopic procedures as they're developed, obviously there are several pitfalls or possible theoretical complications that can occur. In harvesting a plug, one must pay very close attention to minor technical details, where it's very easy to harvest an oblique plug or to go ahead and come too lateral and break off of the bone. In addition, if one comes too medial near the intercondylar notch, they leave a large rim of articular cartilage and start to get involved in the more weight-bearing area of the femoral condyle. If one cannot see the insertion because of fatty tissue, it is very difficult to truly determine the orientation in all four quadrants. Also, one cannot determine where they are in a medial-lateral plane. Go ahead. In this situation, it appears that there's only a very slight discrepancy in regard to the insertion, and one may think that they can make adjustments for that when making the recipient site. It would behoove the surgeon to stop at this point and reorient the plug before it inserts too far. If one waits until it is inserted more than just a few millimeters, when they remove it to reorient it, it can break the plug off and have only a few millimeter length plug. To demonstrate such instance, we will go ahead and obtain an oblique plug. An oblique plug, in this instance, can break out the wall, and as you go in further, there's more obliquity of the articular surface, which is very difficult to match properly in regard to the recipient site. You can see that it blows out the lateral wall, for even though one started in proper orientation, because of the obliquity, the lateral wall breaks free, and also, when looking at the plug, you can see the marked obliquity of the articular cartilage, which is going to make insertion of the plug to match that of the recipient very difficult. Typically what will occur is one portion of the plug will be below the articular cartilage and thus not obtain proper stresses, while the other part will be a millimeter or two proud, which then can have shear stresses and delaminate the articular cartilage. As was mentioned, it's very important that you have a 90-degree angle to the articular cartilage, but also that of your hand to the knee. In this situation, it may look appropriately oriented, but on external, you can see the marked obliquity, which results in breakout of the lateral wall as the graft is harvested. The proper orientation, besides that of matching of the four quadrants seen on arthroscopy, is exterior. It should also be 90 degrees to the plane of the knee, which helps to prevent of improper angulation of harvesting of the articular cartilage. Another technical pitfall that can occur is if one starts to insert the plug and find that there's obliquity, and they wait until it's advanced too far to make any adjustments. Go ahead. Go ahead. The tendency to alter the orientation once the harvester is in more than just a few millimeters results in the possibility of breaking the plug off and having a foreshortened plug of only a few millimeters, of just over 5 millimeters, as seen in this case. One other thing that one has to keep in mind in regard to possible pitfalls, it's very important to try to have the graft flush with the surrounding articular cartilage. If it's countersunk approximately a millimeter, then forces are not applied to that and the articular cartilage has a tendency to die. At the same token, if the plug is left proud, a millimeter or two, there's a tendency for the plug to shear and delaminate the articular cartilage. Postoperatively, one of the benefits of using an Oats procedure, it has much more accelerated rehabilitation than some of the other articular resurfacing methods. My own personal protocol is to have them on crutches for approximately 4 weeks and then allow them weight bearing as they wish. Studies have shown that fibrocartilage fills in the donor site by approximately 4 weeks, and that's the reason for keeping on crutches during that time. After 4 weeks, I let them weight bear as they wish, but most patients are still using crutches for another week or two just due to the leg being somewhat weak. So typically, they're fully off crutches by 6 weeks post-op. At 6 weeks, most patients are off their crutches fully, and at that time can go ahead and ambulate as they wish. We typically do not have them do any real strenuous activities until 3 to 4 months post-op, and typically they can start jogging at 12 weeks following the surgery. My parameters for full activities are at 4 months if they have 80% or greater of their leg strength compared to the contralateral side, they have full range of motion, and have full functional stability such as that of proprioception and neuromuscular function, then they can return to activities without the specific restrictions.
For information on the Arthrex Surgical Skills Training Programs, contact Arthrex at 1-800-933-7001 or visit the Arthrex website at www.arthrex.com. This program was sponsored by an educational grant from Arthrex Incorporated.